Hi, everybody. I am so excited to present our next session, which is titled Pushing the Boundaries of Surgery, Awake Brain Mapping and Techniques. Our presenter is a colleague of mine, Dr. Shawn Hervey-Jumper. He's going to review advances in awake brain mapping techniques. Dr. Hervey-Jumper is an associate professor of the Department of Neurological Surgery. He's the director of the Glial Tumor Neuroplasticity Research Laboratory and the co-director of the Sherry Sobrato-Bryson Brain Cancer Survivorship Program at UCSF. Shawn is really one of the most talented neurosurgeons, I believe, in the whole world. But more than that, he is such an incredibly compassionate, kind, caring physician and person. I'm truly honored to call him my friend. I'm so excited for this session today because he's being joined by one of his patients, Liz Salmi, and they're really going to talk about these advances in brain tumor surgeries and what it's like to be a patient undergo an awake surgery. So with that, I'd like to welcome you both, and I can't wait to hear the talk.
Good morning, folks. It's a real honor to be here today. And this is especially thrilling to spend time talking about such an important topic and concept, important to so many of our patients and families, the role of surgical resection. For most folks, treatment starts there, not with just respect to how we maximize surgical resection and tumor removal, but how we accomplish this safely, how we think about approaching these concepts and the conversations we have. And I am so thrilled to partner with my colleague, Liz Salmi, who's an absolute star in so many ways. But we're going to actually allow her to introduce herself in a couple of seconds here. So here we go. Just as a matter of formality, I have no relevant disclosures. Here are funding sources. And what are our objectives? What are we going to cover? Let's walk down the list. So first and foremost, we're going to talk about what awake brain mapping is. What is it exactly? And we hear this concept and topic a lot. We're going to talk about who is eligible for this type of surgery and when we think about these sort of techniques. We're going to learn about the importance of tumor location when we think about these sort of strategies to remove brain tumors. And last, we're going to explore some of the neurosurgical advances aimed at improving this work so that we can improve patient outcomes. Let's advance our slide to get to Liz.
Hey, everybody. Can you hear me okay? I'm Liz Salmi. I'm a person living with a brain tumor, and I'm super excited to be partnering with my neurosurgeon, Dr. Shawn Hervey-Jumper today. You know, today I work in healthcare, but my early career was rooted in human-centered design and user experience. And I'm always passionate about how to make really complicated concepts much easier to understand. So I was super excited when Shawn asked me to join him for this presentation. In this slide, I share my medical history as a timeline, so you all have some background on me as we talk about this story. This starts with my first brain surgery in 2008. I had a second craniotomy in 2009, which was then followed by temozolomide chemotherapy for about 2 years. After that, I experienced a long period of time where there was no major brain tumor activity in my life, which is a major, great moment to just pause and reset. But here we are. In the last 11 months, things have really changed for me from a healthcare perspective. And that's how I was introduced to Shawn Hervey-Jumper. And as we move forward in this presentation, when we're talking about me, I may reference a mashup of my last 2 surgeries over the last 11 months. That first surgery was about 11 months ago in October. And then the second surgery, which I just had 4 months ago, was in May. Back to you.
I feel like reporters here. This is great. Okay, so this is a great introduction, Liz. You're going to add such great context to everything that we're talking about here. Let's start with this fact. Many of the audience knows, and the speakers also, obviously know that glioma diagnosis is transformed. It's changed over the past few years, and this can be confusing. It's transitioned from a diagnosis made under slides, where pathologists look at slides, to really trying to understand the molecular makeup of disease. So we call that going from histological to molecular classification. And with that has come a whole host of prognostic information that really drives treatment. It's important to note, however, that despite these changes, the current consensus guidelines for all tumor subtypes at this point starts with maximum resection. That's the starting point. Let's talk about some details with respect to how this is done. So, I really like this slide because it really points out where we've come from. This is the summary of a couple of published reports. These are really the hallmark studies that helped us understand how maximum resection improves survival. This particular slide is focusing on patients with glioblastoma, but the truth of the matter is that beginning in 2001, there was an early paper by the Sawaya group at MD Anderson that suggested that yes, surgery improves outcomes for patients, but it's really important that you remove at least 98% of tumor. That was the current understanding at that time. Fast forward a decade, that understanding changed a little bit. This is the Nader-Sinai Berger paper in 2011 that suggested, you know what, surgeons, yes, remove, but the benefit for patients in terms of outcome really starts at about 78%. Then fast forward to 2021, where we start to subclassify patients based on molecular diagnosis, we see two different concepts that emerge. One, that the extended resection threshold is about the same. Two, that removal of the flare, the amount of non-contrast enhancing disease just outside of the tumor, is really important surgical target. So our understanding has evolved over time. This includes an evolved understanding to the point where we start to think about how much flare should and could be removed. This is a beautiful paper that came out just a couple of months ago, and I'll walk everybody through this slide. This is over 1,000 patients, a multinational effort, 12 centers, and it showed that the extensive resection of the amount of tumor that needs to remove should be, if possible, at least 60% and less than 5 cc's of residual tumor in certain settings. And they kind of classify patients according to these red bars and these blue bars. These bars are called Kaplan-Meier curves, and they just show outcomes with respect to each individual type of group or group that you're talking about. And you can see here the red bar is further to the right than the blue bar, suggesting that when you remove this additional amount of tumor that was beyond the previously defined surgical targets, patients did better. Now, these concepts even extend to low-grade disease. This is a publication that's under review, which looks at the interactive effects of extent of how much tumor is removed, even in patients with low grade. We use this term GTR+. That means not just the tumor, but a rim or as much as we can of tumor removed just outside of the margin of what we're calling the tumor. And so here you see this in these, again, Kaplan-Meier curves, these survival curves, where you can see this GTR+, see this line here, this bar with the GTR+, the dark one. These are folks who had tumor removal outside of what we would classically define a tumor. And folks over to the left are patients in situations in which we could remove less than 100% of the tumor, and this is 100%. So there's an increase or shift to the right in terms of outcomes or further longer survival with less tumor you have in your brain at the end of the resection, regardless of whether you're talking about low grade or high grade disease. So these are really important concepts. But everyone in the audience should be thinking this: my brain is here for a reason, right? I should keep as much of this as I can. So what happens when there's severe and lasting neurologic impairments? What does that mean for outcome? And so, this is opens up to a unique conversation that patients and providers have all the time. And I want to play out the conversation a little bit with respect to how Liz and I talked about these concepts when we first met each other and started to think about what to do about her imaging. So I guess let's separate this out into the conversation we had before surgery, when we met in clinic and discussed whether you should move forward with a awake craniotomy, and then dovetail that into the conversation we had in surgery at the time, you're comfortable, your brain is open, we're about to start the procedure, and we check in again.
Yeah.
So let's walk through these questions, starting with the left side.
Okay.
So the first question I had for you is really, I got to get to know you. How do you spend your time, right? What do you do? How do you spend your time? What's important to you?
For sure. It's like a first date. What do I do? So I shared with you that I work in healthcare communications. my work is involved, what's involved in my work is I involve patients and care partners in the co-design of research, and then how to spread research findings from the researchers to the public. So I really do a lot of partnerships with clinicians and researchers, but also with patients and care partners. And mainly I'm like a translator between these two worlds. So healthcare communications, speaking and being able to translate complicated concepts is the work that I do. I've been doing this professionally for about 8 years now. I need to understand a lot of high level concepts, even though I'm not an expert on those concepts. I do a lot of reading, writing. I work with people in different domains. I collaborate a lot. I do a lot of code switching in this world. And so being able to continue to present like this or translate well is really important to me. Pre-COVID, I used to do a lot of travel and go to conferences, but that died down over the last few years. So I do online presentations. And then really what's important to me in my work is to I remember telling you this, you're like, what's important? I said, my ability to be creative. How do you preserve that? I don't know. Good luck.
Yes. So let's code that back. Let's walk that back. So as a provider, what I was hearing is that we have to preserve her ability to communicate. After a requisite amount of recovery time, communication is important. Problem solving is important. Processing speed, or the speed at which she can solve complex problems, also important. Okay. And then we segue that into a second question, which is important, which is describe to me some of the important aspects of your life kind of outside of work. What else do you do with your time?
So I remember sharing that I'm always working in my mind, like just problem solving. But when my husband says, stop working, you need to stop and sit down and chill. I'm married, my wonderful husband, Brett. We've been married for a little over around 11 years now. We have a cat, Mark, but we have no kids and we're not planning to have any. Since I've been living at that point when we first met, I was living for about 14 years with a brain tumor. I really placed a priority in my life on living and having experiences and doing travel. I've had a chance to live with a brain tumor for so long that I've now seen these survival trajectories of like what to expect. And I was like, oosh, my time is coming. Let me just live and be out there as much as I can. I really want the time I have to matter. And it's like, how do you do this well? I shared with you that my physical health is really important to me. After brain surgeries 1 and 2, I started strength training and working on my balance and kind of brain physical retraining or making stuff up as I go along, because there's really no path for that. I work with a trainer, and I see all of this as important as my brain and my parietal lobe continues to recover over time.
Great. So what I was hearing at that time was she's super active, and has a lot of kind of extracurriculars and things that she loves in extracurriculars, as though you're in school, but a lot of life events and things that she's doing outside. But activity, mobility, communication still is a big problem, a big issue, something to preserve. And so what we have to do is think about when surgery would and should be stopped. And so we start to have that conversation about what sort of risk we're willing to take upfront. And then we proceed through, talk about surgery, get into the resection. We have a brief conversation about how things may or may not have changed since our last conversation. And an important concept came up in that discussion at the time of surgery. Beginning the resection, we're marching the resection towards the important areas, and you started to talk about your face. Could you recount that a little bit?
Yes. So I think making sure I'm following on with you. So we have this whole discussion about what might happen during surgery. Then it's surgery day, it's go time. And you wake me up in the OR and you start, testing and pulling pathology and tissue. And now you're talking about, you have a question. I just want to make sure I'm on the same page with you, that you've pulled as much tumor as you can. You've done all of the language mapping and physical stuff. And now there's a point where you are testing my sensation live and saying, Liz, where do you feel this? Where do you feel that? Am I following along with this correctly? Okay.
Yep, you're exactly right.
So I'm now talking about you like as if you're not here, but to everyone else. So Dr. Hervey-Jumper, Shawn, is using this stimulator to touch my things in my brain to make me feel something. And he's like, where do you feel this? Where do you feel that? And I'm feeling kind of this marching up my arm, these sensations. It doesn't hurt at all. It feels like a little buzz or something. And it says, where do you feel that? And ultimately, you get to a spot where he's like, you say, where do you feel this? And I'm like, I think I feel you in my face. And I have dimples, and I can feel when I am smiling that impression of the dimple on my face. I know that feeling very well. And so you said, where's this? I said, you are in my dimple. And so there was like a pause moment. And you say, time out, and you come, the whole time you're kind of back here hovering because I don't see you, but then you come around and you want to have a one-on-one discussion with me live during surgery, and you come around and you and I are face to face. And you said, okay, we're at a point where we need to make some decisions here because you're in your face and I am in your face. And, at this point, as we go further into tumor resection, I think I'm saying this correctly, we need to decide, I don't know, you may, if we continue moving forward, there may be some lasting effects of losing sensation in your face.
That's right.
Do you want to move forward with that? And
yeah, no, you're exactly right. And that was a stopping point. You gave me a stop point. You said, listen, these dimples are important to me. It's part of my identity. When I look in the mirror, I want them there.
Yeah.
And we set that as a discussion point, and we had that discussion. And when we got to that point, and we decided how much more or less to remove. And that's really at the heart of these sort of functional mapping procedures, where we're driving the resection to a point that's agreed upon by the patient. And this is, oh, you had something to say?
I also want to say, getting to the dimples in my face was not something we talked about in advance. We didn't know where we didn't know that dimples would be a marker. I didn't know. And so there was a moment where I don't know how long I spent deciding, yes, I'm ready to go forward. But it was a surprise. And I think you didn't know how much they meant to me either. So I think it was really like the fact that you do awake mapping is crucial because it allows me the opportunity to tell you this is important to me in real time, because there was no way we could have predicted this would be a decision point in our pre-planning discussions.
Absolutely. Let's talk about why that's so important. Oops, I advanced twice. Why that's so important. And it was so important because as we think about outcomes, there's certain types of impairments that are more important than, or more significant on outcome than others. So again, if we talk about trying to maximize extended resection, we can quantify what types of neurologic impairments significantly impact outcomes relative to others. So on the right side of your screen here, you see each individual oval here represents a risk factor. Outcome turns out for patients with glioblastoma is determined how much by the presence or absence, by the use of this chemotherapy drug, by your IDH status, your age at diagnosis, and turns out how much of that residual tumor is removed, how much of that tumor is removed even in the white stuff, the flare region. But if we cause neurologic impairments, look at this box here, the types of neurologic impairments that most significantly impact outcome include long-lasting hemiparesis, meaning the inability to move your arm. And again, this shows almost a 4% greater chance of a worse outcome compared to those who can move. And so this is a point of mapping, to try to identify those important sites so that we can limit the risk to patients. I'm going to skip past this slide and get to a couple of important concepts here in the interest of time. So we talked about functional mapping permits the surgical team to maximize resection by minimizing morbidity or minimizing harm. In that concept, I think it's really important for the world to know that we cannot necessarily agree on what function actually means. We use this term preservation of function, functional preservation. And this is a fun slide I like to show, the audience doesn't have to look at these individual points here because you can't really read them. But what it shows is 5 years of publications, over 160 publications, of which there's very little consensus about which of these functional outcomes actually represents real world. By real world, I mean how you, Liz, are doing on a given day, like today. We use proxies, or we use estimates like patient-reported outcomes, cognitive assessments, activities of daily living, well-being scores, seizure burden. These are all different types of metric we use, and they probably all interact with each other, but really we're trying to understand how you're living your life. Who's a candidate? Well, any person with a brain tumor located within or close proximity to a region that may have language, sensory, motor, or cognitive function on a preoperative MRI, okay? For example, Liz had a tumor in her left parietal lobe, which tells me that we should really be looking out and thinking about movement, motor function, language, and sensory, or where her body and limbs are in space. Those are important aspects. But there's also higher cognitive processing there that I'm thinking about as well. This is a slide I like to show here because it gives you an idea of all the different types of mapping, the types of tools that and mapping techniques or mapping tasks that surgeons can use in the operating room. Again, the text is too small to read, but it really varies based on which part of the brain you're working in. The insula has a certain type of testing strategy. Frontal lobe has a certain testing strategy. Parietal lobe is different. So these conversations between patient and provider are critical. When we get to surgery, there's so many different team members that are taking part in your surgery. Liz pointed out a really important concept. This patient is naked. People are not naked in surgery. I could not figure out on PowerPoint how to put a little box of clothing. But you can see all the different people that help out with surgery, from the anesthesiologist to the neurophysiologist, all the functional mapping team people, epilepsy people who are helping us understand whether you're having seizures or risk of having seizures in surgery. We focus on language a lot because language processing and communication is so important. These are the different types of language tasks that we use. Again, it breaks language down into the elemental parts so we can test each different part: naming pictures, counting, reading words, reading sentences, interpreting sentences or interpreting syntax. These are all really important strategies and concepts that we think about and apply in surgery. But these are pretty old. We've done this for decades. I promise you we talk about some of the newer concepts. And it's important to think about some new tools and tricks and tips that we have in surgery. This is called triple motor mapping, and this is a new technique that's evolved over the last several years. And it basically allows us to use multiple modalities to test motor function or different types of cognition function even. It involves putting an electrode on the surface of the scalp and using 2 different types of electrodes, one that stimulates the tissues just in a local area, and the other that stimulates the tissue looking for function. So it gives us a proxy or measure of how far we are from the important structures and pathways in the brain. So at the same time as the surgeon is looking at the integrity of the entire system, of how well the entire motor pathway is working, we're also getting direct feedback of how close we are to these important structures, which has really improved safety. This is what it looks like in reality. Here's an example. Have a patient with this little white thing here. That's it. That's the tumor. Here's red is the movement fibers. We could take a couple of different approaches. This is a different way. This is the brain surface itself. This is the white box is the movement fibers. The black in the front is where we could go. We can go from the anterior or front direction. The black circle in the back is where we can go from the back direction. This patient happens to be involved in the IT world. There's a lot of fine motor movements, so the risk to them would be lowest if we came from the back, from this black circle and the green circle there. And so we do that. We approach from the back side, and then we use a number of different tools in surgery to not only measure how far or how close we're getting to the movement fibers, but also measure the amount of tumor that we're removing and that's remaining as we inch closer to the movement fibers, okay, as we inch closer to the important parts that we have to keep. So in reality, what you end up doing is removing the entire area, except you leave a little spot in the top where we get very close to the movement fibers so that the patient can get back to living a normal life after a recovery period. We're going to finish with one slide here, and I think it's really important to have Liz finish us off by talking about what surgical recovery was like for her and kind of how this process evolved after the procedure.
Yeah, thank you so much. I think thank you for it says so much about Dr. Shawn Hervey-Jumper that you invited a patient to do the last slide on your presentation. Thank you for you. And I think it's really important for all patients to know that, being supported by your surgeon is crucial to your next steps in your recovery. As patients, everything we do before and during surgery really sets the table for then everything we do after, from treatment to no treatment. This is our roads to recovery. You can't compare each other, other people to other people, and don't compare yourselves to me. Where our roads to recovery are as unique as the treatment itself and our brains themselves. So thank you for having me.
Great. I think I can advance to, okay, this is our disclaimer, and we'll stop with this. Community, thank you for allowing Liz and I a few minutes to share these experiences with you. This is contact information, and I think, Dr. Ryan Bush, we have a few minutes to maybe field some questions.
Yes, we do. Thank you so much for that wonderful session. Just as a reminder, if you do have a question that you'd like to ask, please type and submit it on the right-hand side of your screen where it says Q&A. Click the blue Ask a Question button, type your question and hit submit, and we'll answer as many questions as time allows. All right. So just give me a moment. All right. So one of the first questions we have here is asking, how does brain tumor location impact or influence your ability to perform an awake craniotomy? Are there certain tumor locations that are just not appropriate for awake craniotomies?
Yeah, well, that's a great question. Again, this is all individual. It's about not just location, but what we're trying to preserve. And there's what we call a localizational view of the brain. That means that different parts of the brain are responsible for different functions. And so there are some locations in which the function is so critical that accessing it could result in more harm. Take, for example, certain parts of the brainstem, right? There are certain parts of the brainstem in the central areas of the brain where, for example, movement and other types of processing in the brain are so tightly packed that accessing them would result in severe impairments. And we saw that there's an interplay between impairment and outcomes. So if our treatment, if our therapy would cause as much harm or more harm than the tumor itself, then we should probably not go there. And so, yes, there are some locations. Many gliomas don't end up in those locations, thankfully, but there are locations where we pause and say that's not a good idea.
Thank you so much for sharing that and for providing that clarification. So Liz and Dr. Hervey-Jumper, you both seem to have a fantastic relationship. What advice can you share, Liz, I'm going to direct this one to you. What advice can you share for patients that don't have that type of connection with their surgeon? They don't have as easy of an ability to connect and speak with them. How can they advocate for themselves? How you talking about what was most important to you, so you can ensure that that was preserved. Yeah. I think asking, this is a two-way relationship. There's, as a person who's been since I've been living with a brain tumor for a long period of time, I've learned a few things over the years. And I know the importance of self-advocacy in being able to communicate what matters most to me to my surgeon. I think from a physician perspective or surgeon perspective, and feel free to correct me if I'm wrong, Hervey-Jumper, but I think that's called goals of care, like figuring out what matters most to patients. And then I want to communicate clearly to my doctors, any type, what is meaningful to me. And I'm a very curious person. I want to know everything. And not everybody's that way. So when I first met Dr. Hervey-Jumper, I tried to communicate, he didn't know me from every other patient. So I was like, I'm very curious.
I want to know all of the things. Let's get into the details. And I worried he would think I was asking too many questions. And so I wanted to share, I wanted to communicate in our very first meeting, here's who I am. And I was hopeful he would be receptive to who I am. And thankfully, I think we ended that very long first visit with him realizing that I'm interested in knowing all of the things. And I think it requires me to advocate and share who I am, and for him to be receptive. And I don't know if all surgeons are that way, but I really hope they are, as they are more exposed to colleagues like Dr. Hervey-Jumper.
Thank you so much for sharing that insight and advice. We'll take one more question. So this question is asking, when you're performing the surgery, Dr. Hervey-Jumper, this one's for you. Can you use, or do you use, products like Gliolin to enhance the image and your ability to see the tumor?
Absolutely. You know, Ambreen, you should have given us another 5 minutes to talk, and we could have talked about these sort of things. So yes, thank you for asking that question. There are so many tools. Like we highlighted just a couple of different newer techniques and tools used. What this excellent question is getting at is, how do you identify, how do you see tumor versus non-tumor versus normal? Gliolin, or I should say 5-aminolevulinic acid is the name of the compound, is a drug that's given. Your body turns it into something else, which makes tumor cells glow a fluorescent pink color, salmon pink color. There are those sort of approaches. There are also non-label or label-free approaches, which is the one I put on the slide. They're all great approaches, but in things that surgeons can use in surgery to identify, hey, have I removed, am I doing the job that I said I'm going to do? I've removed the tumor and got to the edge where I can then start to think about normal brain and normal interactions. Gliolin, or 5-aminolevulinic acid, is just one example of those types of tools that we have at our tool belt to use for safe surgical care.
Thank you so much for sharing that. And I do wish we had more time, because there's so much more that we could go into, but that is all the time that we have for questions for this session. I'm going to turn it back to Emily, and we'll move forward with the rest of the program. Thank you again.
Thank you.
Thank you, guys.